Good morning, everyone, and thank you for joining the CQC team for this webinar on patient engagement in virtual care. We're delighted you all are here to join us today. As a reminder, this session is being recorded and will be available to you after the webinar is complete. We are sharing right now a PDF of the slides for you to download in the chat, and if you would like to follow along. However, these slides, the recording, as well as the URLs mentioned, will be sent via email to registrants after today's webinar. Before we get started, here are a couple of Zoom tips. If you would like to speak during the Q&A section, you can mute yourself through your computer controls and phone by pressing *6. If you have any questions or comments, please utilize the chat box and we'll moderate and answer as best as we can. We will also have a few polls. So make sure that when you select your answer, to click the submit button so your answer is recorded. If you have any technical issues, please direct your message to me, Jose Ordóñez, and I will do my best to assist you. At this moment, I would like for everyone to please chat your name and organization in the chat box. Welcome, everyone. Okay, and to get started, let's do our first poll of the day and hear who has joined and from where. So we're going to launch our poll. And I see there's a lot of presentation from the Los Angeles area and the types of organization. I see there's a lot of nonprofit this time. And we have a couple other ones as well too in the chat. Okay, I'll give you 10 more seconds. Please submit your answer. Click that submit button. Great. Yes, it's here. Well, lots of people from Los Angeles, but from other areas as well too. So welcome everyone. And then we also see a lot of people from IPAs and others as well too. So welcome everyone. And at this moment, I would like to pass this virtual stage to Christina.
Thank you so much, Jose. And great to see the wide range of interest across organizations for this topic. So my name is Christina Modi, and I'm Senior Manager of Improvement Advising here at the California Quality Collaborative, or CQC. CQC supports quality improvement in healthcare in California. During the public health emergency, we've been hosting regular webinars for small practices and IPAs and providing peers and experts opportunities to share experience and advice as practices implement telehealth on an incredibly fast timeline. After the webinar, feel free to access the CQC's COVID-19 resource page, which includes a bunch of external resources as well as all our webinars. Michael from the CQC team will put that link into the chat. Next slide. So, we've been living the rapid implementation of telehealth. By one report, telehealth visits have increased 14% nationwide, and by some estimates, 16 million Americans have used telehealth in the past few months. Today, we're dealing with a new reality of planning some care in person, but also hoping to continue the gains and sustain the virtual care implementation. Now that they've tried it, patients agree. When surveyed in early April, 88% of new telehealth users said they would try it again. Anecdotally, I've heard some wonderful stories about 97-year-old patients being able to log on for their first virtual care visit because of experience with FaceTime and FaceTiming their grandchildren. But we also want to make sure that virtual care being offered is truly patient-centered and also meeting the diverse needs of patients, especially those who have greater challenges getting online. Next slide. So with our webinar today, we're here to address some of the challenges we know you're dealing with, including how practices can do effective outreach to all patients, understanding how patients are understanding virtual care, and what you can do today to make virtual care more patient-centered as an organization and a care team. Next slide. So before we turn it over to our wonderful guest speakers, I want to ask you to take a moment, reflect, and share in the chat 2 pieces of feedback you've heard from patients regarding their experience of telehealth over the past 2 months. One positive and one not so positive. I'll pause now to let you think and share your experience in the chat. So we have, Michael, would you just like to start sharing some of the chat responses?
Sure, no problem. Seeing here from Evan Polanski, just heard it's very convenient. Unfortunately not positive. They like seeing doctor in person. You can understand that, having that physical connection. Let's see, provided easy access without worry about transportation. From Deanne McCowan, for my 80-year-old father, we are going to continue doing video visits after this pandemic. So that's certainly a positive in terms of having that modality. See, from Libby, oh, sorry. Ease of not having to get childcare. Pay for parking is easy. Another from Evan Polanski, not positive side, the technology can be hard to use if it's something that's new. Thank you for all these comments. They're coming in pretty fast.
Yeah, I think we're seeing some trends of patients really appreciating the logistical ease, care continuity when possible of seeing provider, and also increased access, but also hearing that there are some barriers around technology, and also really making sure that they're having feeling a warm human connection with their provider and care team. Privacy was also another issue that was brought up. So I think we hear some really great foundations to build on, but also some opportunities that practices can think about improving for in our next phase journey. So thank you very much for sharing and keeping those reflections coming. So let's go ahead and go to the next slide, and I'm going to go ahead and introduce our great guest speakers. Today's panelists offer a wealth of expertise and on-the-ground examples from research, patient partnerships, and care delivery. Each of our speakers will have about 10 minutes to share their knowledge and perspective, and we've reserved time for joint Q&A. So feel free to chat in your questions, but we'll likely answer them during the 15 minutes we've reserved after our final presenter. Our first speaker, Dr. Courtney Lyles, is an associate professor at UCSF's Division of General Internal Medicine, the Center for Vulnerable Populations, and the Department of Epidemiology and Biostatistics. She's a trained health services researcher who examines quality of care, health behavior, and health outcomes, focusing on health information technology to improve care and reduce disparities in health and healthcare outcomes for low-income and minority populations. Our second speaker, Libby Hoy, has over 20 years of experience navigating the health system as a caregiver to 3 sons living with mitochondrial disease and as a cancer survivor. She's founder and CEO of PFCCpartners, which was launched in 2010 to support health systems, payers, researchers, and quality improvement teams to partner effectively with people using their lived experience in the health system to improve it. Partners include National Academy of Medicine, PCORI, CMS, and the National Quality Forum, among many others. Our third speaker, Dr. Fiona Wilson, trained at Harvard Medical School and UCSF and practiced primary care for many years before moving to medical group administration as Chief of Quality, Chief of Clinical Transformation, and finally Chief Medical Officer at Brown & Tolan Physicians. She worked with CQC's Practice Transformation Initiative as Medical Director and Clinical Advisor. She's been working for Teledoc, a national telemedicine company. Dr. Wilson recently took a role as Supervising Clinician Specialist in the Department of Human Resources for the City and County of San Francisco, with a focus on supporting employees and ensuring a safe working environment. So with that, I'd like to turn it over to our first speaker, Dr. Courtney Lyles.
Thanks so much, Christina. It's great to be here to speak with all of you. I'm doing this from my phone since my computer's having problems, so hopefully it'll all go well. So you can go to the next slide. Today, I was going to talk mostly about some things that you actually set up really well in your opening remarks, Kristen, about like what it looks like to do care delivery in this time. I was going to show some national and local data on things that I think are fundamentals for thinking about a telehealth transformation, like device ownership, high-speed access to internet, and digital literacy skills. And then because there's not actually a lot of research known about telehealth, a lot of the research is really in the specialty care and in different kinds of delivery systems. I don't think at scale we've actually done telehealth for the bread and butter primary care and specialty care delivery in our country. I was going to share some lessons learned from previous work, and I think there's some parallels from engaging patients and using the patient portal that may be useful. And then end with some strategies. So next slide. So I don't think this is new to you. It's sort of parallels that Commonwealth Fund slide that you shared. But this is, a recent and several week look at the number of visits in blue, which are in-person office visits, and then obviously the switch to telehealth in green. And I just wanted to point out here, not only have we radically changed how we deliver care, but we've also had a drop off in care for the most part. It's coming back up, it seems like, today, but we, in the Center for Vulnerable Populations, of course, are thinking a lot about who has dropped out of care in this crisis and how they've been accessing care, especially given that everything is virtually, is either virtual or phone at this time. So on the next slide, we pulled some data from, this is actually from UCSF Health. We had some similar data from San Francisco General, where I'm based, but we had the best data available from UCSF primary care, and we looked at the blue bars being prior to COVID and the orange bars being the first 3 or 4 weeks post-COVID, who sort of was accessing care, who was able to get into telephone and video appointments, and by the characteristics that we might be most concerned with, like age and language and and how that relates to insurance. For here, that there was definitely looked like some trend down in some of the potential populations who have communication barriers, especially through remote technology. So moving on to the next slide, I thought, that doesn't surprise me too much given what we know about some of the national data. So I share a lot of this in my work just in case you haven't thought about the digital divide from sort of a different lens. Knowing that, of course, telephone visits are really a possibility and frankly are being used almost exclusively in our safety net delivery system at San Francisco General right now, but I think we all want or are looking towards video visits as well, especially to have that interpersonal connection and to see the patient face to face. I think we're trying to push for real access to video visits and like Kristen has said, not just now, but hopefully continuing that into the future. So in order to do that, I think we need to really look at the data about who is online. So you can go to the next slide. Across the board, this is just by income, the rate of people who are using the internet by income categories in the United States. This is Pew data. And I would say there's a lot of trends upward, as you can see here, in internet use and in smartphone ownership, and especially a closing divide by race, ethnicity, and who's using these modalities. But especially when you think about income and age, as well as community, like urban versus rural populations, which probably isn't new to many of you, there actually is a pretty big gap especially for lowest income Americans and for older adults in the United States. For even having an internet at home or owning a smartphone. And then on the next slide, you can see that there's also sort of a second angle on this digital divide in the United States, which is now the blue line, which is the lowest income Americans, is on top, which is really about smartphone dependency. So this idea that low income Americans have had a pretty strong increase it's a quarter of low income Americans now are only using their smartphone to access the internet, and without any broadband at their home. And what that means is that they're obviously online in a different way, but they are likely on data plans that have limits on their data plan, or potentially lower quality data plans and speed of data plans that might inhibit their access to doing potentially a lot of digital health technologies, but particularly video visits. We're not going to take up their data plan or their bandwidth just to potentially call into their doctor's office. They might want to preserve that for other information. So you can go to the next slide. And then the last piece I thought I would just touch on briefly is about the literacy skills, the digital literacy skills. So this is now local data rather than national data. This is here in San Francisco. And we are really fortunate to have an initiative of digital equity that lives within the mayor's office here in the city and county of San Francisco government, where they did a recent survey of San Franciscans, in a very well-connected urban environment, about internet at home and also self-reported digital literacy skills, like being able to complete an online search or finding websites, sending an email, things like that. And the dark blue bars are people who both are internet users and who have reported that they can do basic digital tasks online. And overall, it's pretty high, over 80% of San Franciscans. But when we look at some of the same groups that in my work, I'm really focused on, non-English speakers, older adults, and low-income San Franciscans, we're really hovering around the 50 to 60% range of individuals who have both of those things. And so I put this here to say that literacy is also a pretty big need, and how to think about embedding literacy when introducing a new modality. Excuse me. Next slide. And so then I thought I would share just a couple more research lessons. Of course, happy to take questions and things like that, just showing lots of different studies, hopefully not too overwhelming, especially about patient portal work. So on the next slide, really when we think about patient portals, so patients accessing their electronic health record data on their own, we've been studying that for over a decade now, first in Kaiser, who offered it first, but also now in a variety of healthcare systems. And I think a lot of research boiled down into a few bullets here, but the idea that the interest is really high in these kinds of services. So when the statistics you showed, Christina, that 88% of people who have never tried it wanted to do it again, doesn't super surprise me, because we've seen this now for a while and a variety of others, that they actually really electronic and digital communication tools to do healthcare, mostly for convenience, which was also chatted into the chat box here, not being able to have to come in person, all the barriers that go along with that. So that's pretty well documented, but of course we see differences in who uses patient portals by some of the exact same factors like race, health literacy skills, and language and income. And all the qualitative work that's been done in that space also harbored back to what you guys chatted into the chat box about the reasons why people might not be using it is preferring to have an in-person visit with their doctor, seeing somebody face-to-face, a lack of perceived need to do the patient portal work, which is interesting in the time of pandemic, to think about this as maybe there's one silver lining in this whole situation, is that there is no other option sort of right now, and how can we take advantage or think about what that means for the need piece of doing a visit and potentially trying a video visit with somebody. And then of course the digital things that I just mentioned, that goes hand in hand with the ability of the health system to actually provide technical support to people. So getting locked out, passwords for patient portals, some of that is less prominent if you just have to use Zoom or other relaxed regulations now to do video visits through other means, but really knowing that somebody would answer your questions actually came up quite a bit among the patients in these qualitative studies. And then the last thing I would say is, on the portal, there's lots of jargon, and so there's, of course, communication barriers for those who have limited literacy or English proficiency skills, but I think this translates in video visits into the use of interpreters appropriately, how to think about the security and the privacy where people who live with many other people, how to actually think about the environment or the supportive environment around delivering a new modality like that, and how can we think about that when we want to engage patients in using these types of things. Next slide. And so this is just a pretty busy slide, but I thought I would just say that the other point here is that you can train people and support them. So when I say technical support, I both mean some introduction to it as well as some ability to answer questions ongoing when people get set up. And we've done a couple different training studies that are cited at the bottom here. On the left-hand side is a portal training study for low-income individuals at San Francisco General. And the blue bars is those who got some training, and the red bars is just everybody else, showing that you can get a pretty significant increase in patients using things like patient portals when you provide a training. This was just a one-time, really brief training, so I don't think it clearly didn't get a majority of patients, but how can you combine training with other things to get us into the majority category? And then on the right-hand side, this is actually a training program of older adults learning how to use an iPad for the first time in their home. And you can focus on the right-hand side of the slide with the 0, showing that after we trained them, and this was a 8-week training where someone came in person to their home for 8 weeks and trained them how to use an iPad and answer their questions, everybody was online. And in the quote at the bottom, the seniors had a lot to say about their confidence, right? Not only are they learning the skills, but they're actually learning the ability and the confidence to be able to try technology. And so how do we think about training as a necessary component of doing this, given that we have a lot on our plates? So next slide. So to summarize, I think I would say in a healthcare system, we need to be really messaging about these kinds of visits, video visits and telephone visits, as extending and maintaining in-person relationships, and really thinking about that it's not a replacement or a substitution for their ongoing relationship with their doctor. It's really a different way and a more convenient way to maybe do other types of modalities. And in this pandemic, potentially their only way to connect in person, interpersonally, but hopefully we'll get back to in person later on. And potentially also understand what their barriers are if there's a chance to do that. People have different barriers and preferences, and how do you match what you're offering based on what they want? At the provider and system level, I know we screen for so many things. I'm not here. I think you do really need to know if people have a device, what kind of internet they have, and their skills before you can offer something effectively to them. You have to then deliver the technical support, if you can, to them to be able to use the technology. And then I think we really need to think about how to do this in a team-based way. We're in a world of telehealth, and I think a lot of it has sort of gone back to that patient-provider dyad, and maybe we need to figure out how to deliver the team element of what we're doing in a virtual way as well. And then lastly, at the higher, more policy level, from my personal standpoint, working in this digital inclusion space, there's lots of other resources out there that I think we could be doing a better job in healthcare, reaching out to public libraries, local government agencies, and community-based organizations who actually work on this as a digital access and skills on a daily basis, and how can we bridge those gaps? And then, of course, I think this pandemic has shown a light that hopefully we can, as a healthcare industry, talk about how broadband is really important for us, the same way that those in education and those in employment have also been speaking about that right now, knowing that we can't do any of these things right now unless people have high-speed access to internet and devices at their home. And then I think I have one more slide, which is just a few more resources. If you're interested, we at the Center for Vulnerable Populations put up some more resources for working with interpreters, a sample workflow of offering video visits to our patient population if it's of interest. And then, of course, the National Digital Inclusion Alliance and the Center for Care Innovations that have more information focused on especially lower income individuals and how to think about them during this time.
Mm-hmm. Thank you so much.
Thanks.
Yeah, thank you, Dr. Lyles, and thanks for these resources. I'll mention that the Center for Vulnerable Populations is linked on the CQC website too. We didn't see any clarifying questions coming through the chat, but please, if you're thinking about any, chat them in and we'll take them in the broader Q&A section. We're now going to transition to our second speaker, Libby Hoy, who will talk more about what patients are experiencing and saying about virtual care. Before we do so, let's do a quick poll. Jose will launch that right now, but we want to know, what do you think or have you heard is most important to patients when using virtual care? Ease of use, confidentiality, knowing the care teams or providers, the ability to address a health concern, or other? Feel free and chat it in. And don't forget to hit that submit button. So Libby, I think we'll give a few more seconds, but we're seeing kind of a split between ease of use and ability to address health concern.
That makes sense with a lot of what we're hearing as well.
Yeah, looks like 52% say ease of use, 36% say ability to address health concern, and lower ranked is knowing care team providers and confidentiality. So thanks for giving that feedback. So now, Libby, I'd love to hand it over to you.
Fantastic. Well, thank you so much, and thanks for that wonderful presentation. Really lines up incredibly well with what we're learning from our patient and family community. So next slide, please. You heard a little bit about PFCC Partners in the introduction, but essentially we are here to help healthcare organizations and patients and families and administrators as well as clinicians to connect with one another, because we really feel like when all of those perspectives are informing the way that we design care, we improve outcomes together overall. So it's very much a partnership model and perspective. Next slide, please. The staff of PFCC Partners are all patient and family active users of the healthcare system. We all continue to partner with health systems in the role of patient-family advisor, which we define as a person using their lived experience in the health system to influence it. In addition to our own staff, I should say, we support the PFA network, and that is a group of over 600 patient-family advisors like myself who are partnering actively with health systems, with quality improvement organizations, measurement developers, research teams, anyone who will speak with us to partner to improve the healthcare system overall for all. The PFA network is really important to our work at PFCC Partners because it gives us a broader perspective than just our own across the healthcare system. So we really have a great sense of community. We do a great deal of skills exchange. We don't call it training because we're always learning together. And so we convene opportunities for us to learn from one another and really increase our capacity for partnership. And then finally, we serve as a touch point for engagement. So folks and teams that are looking for regional and national advisors to participate in their projects will do a bit of a matchmaking service. But again, that allows us to tap into a larger, broader network of patients and families who are partnering in the advisor role. I should say that we have a great deal of regional diversity, so we've got lots of rural health advisors, we've got lots of urban, low income, and we also have age diversity, we have lifestyle diversity, we have ethnic diversity or cultural diversity, although not to the degree that we need, so that's something that we're always working on, but we really cultivate a very diverse and inclusive community. So next slide, please. So I think it's always helpful to level set with how I'm thinking of these terms as I'm throwing them out there to you today. So PFCC Partners looks at patient, family, or person-family centered care as the model or the noun. It's the culture of care that we're implementing where we're allowing and inviting personal preferences and priorities to inform our care plans. Then patient-family engagement becomes a verb. It becomes action in the way that we do that. We're engaging with our patients and family caregivers in a way to improve outcomes. And when we think about patient-family engagement as an active strategy, we can then apply it to any outcome, right? So whether that's my individual care plan and my individual outcomes, or whether that's improving patient safety and reducing infection rates in our health systems, whether that's improving patient experience. I know a lot of the organizations on the call today are really focused on improving the patient experience, or whether we're trying to improve high quality care. It's this engagement as an active strategy that really helps us to get there together. It puts those cogs that are in our logo into motion together. So I want to kind of go back just a moment in terms of the conversation about the patient portals and the opportunity that we have here in front of us with this massive shift to telehealth as quickly as we are moving. Patient portals have been a wonderful resource, and they really are the potential for them. I don't think we've even gotten near to the capacity of what they could really do to support the clinician and patient relationship. And one of the reasons that I might challenge would be because patient portals were largely designed and produced without patient input into them, And we found that that was true through some of the work with the National Health IT PFAC, who did a perfect patient portal project where they designed the perfect patient portal from the patient perspective. And so we saw some of the differences in the ways that the patient portals were stood up very much with limited influence from the ultimate end user, or one of the ultimate end users being the patients and families. Here we have, with telemedicine and telehealth booming, this same space, and it feels really, I have a sense of urgency about how we are going to engage the patient and family caregiver perspective as we develop telehealth. You know, I think we can sort of acknowledge that we're building telehealth as we're flying the plane a bit, and so this is a very unique opportunity to engage patients and families as an active strategy to developing telehealth systems that are very effective for clinicians, for patient outcomes, for patient and family caregivers accessing. So that's sort of how I'm thinking about these opportunities that are in front of us. And I think that there's, as we build in that continuous improvement from the perspective of the patient and the family caregiver, we're going to get some really relevant and improvements that are going to help to create equity. So I'll go to the next slide and kind of come back to that thought as well. So I think what we've heard a lot of with our patient family advisors is that it's just a little bit messy out there right now. And quite frankly, the advisors that we've heard from are feeling, and all of our advisors are representative, of course, of their local patient communities. But what we're hearing is they want to be invited into the mess a little bit. I'll give you a quick example from my own perspective. I had my first telemedicine interaction with my primary care not too long ago, and they're not up with virtual yet, and so we did a telephonic visit. And she was checking in with me and saying, you know, does it hurt here? And I said, well, I can't see you, so I don't know where you're pointing. And then I said, no, not right there. It hurts more over here. And she said, well, I can't see you, and I don't know what you're pointing at. And so I think that kind of transparency and, you know, just sort of bringing the patient and the family into kind of the mess allows us to develop what we both need together. So we've been kind of thinking similarly to Dr. Lyles' comments about the patient, or the virtual visit in the context of a larger relationship with the primary care. And I think that's a really important piece. So I think we've been really focused on the visit piece, that middle section, and need to think about our expansion into the pre-visit area, which is something that we've heard a lot of from patients and families. But even, I think more so, we're hearing much more about the post-visit and what happens following that interaction. So with the pre-visit, I'll share in a moment the virtual visit guide, and you'll notice that I'm using the term virtual visit. That came from our advisory community, who felt like telehealth, telemedicine felt very cold. It felt very structured in a way that wasn't matching kind of this need for flexibility in the environment. So they felt virtual visit was much more comprehensive in that people are experiencing this very differently. Some systems have telephone visits, some systems are using Zoom, some are using FaceTime, some are using complicated platforms that are built into the patient portal. So from the patient perspective, if I am receiving primary care from you and specialty care over here, I may be encountering several different platforms. And so we felt that the term virtual visit was much more comprehensive and inviting. The opportunity to practice the technology, I think we've heard that a lot from patients and families, again, acknowledging that we may be ramping up to learn 4 or 5 different platforms, and so that's really important for us. We even had an advisor share with us that their organization actually used 4 different platforms within one organization. So depending on what clinic they were seen in, they were experiencing a different platform, and that Patient Family Advisory Council was able to bring that to light, and they have since then moved to one consistent platform. So just recognizing that. Ensuring confidentiality, I think we heard that as a concern. Interestingly to me, not as much of a concern for folks as I would have thought ahead of time, ahead of these conversations. But I think one really easy way to help patients and families feel a little bit more secure in that is to let them know, and we've heard this, to let them know the context. So many of our clinicians are actually doing virtual visits from their home or from their home office. So acknowledging where you are and who might else be around, if you're in an office with the door closed and you're in a private room, acknowledging that and letting them know that can be really helpful. Focusing on the efficiencies, you know, again, as someone who cared for 3 children with special healthcare needs and 6 different specialists, and lugging oxygen tanks around and G-tube supplies and all the whatnot, the efficiencies are a thing for especially our chronically ill families. This is something we've wanted for a really long time, this opportunity. So I think that's very helpful and confidence inspiring for a lot of families. Offering a prep call, and again, if you have access to patient family advisors or your health system has that, this is a great place for peer support. This is a fantastic place for peer support. In all of the calls that we've had with patient family advisors around virtual visits, we've heard things from, hey, if you don't have broadband or you don't have access to the internet, you can go drive to any restaurant parking lot and they usually have them, so you can just tap into that. Or we can go to the local libraries, as was mentioned before. We had a patient group up in Washington State develop a map of their community of all the places you could go and park and sort of poach off that Wi-Fi. And so you're really engaging them and making space for your patients and families to help you problem solve. It can be really effective. Safety information, again, just including you know, where they are, if they're in a safe space, making sure nobody's driving, making sure, you know, all those kinds of things. And then making room for your patients and families to ask questions. During the visit, I think we've heard a lot about this, you know, just acknowledging the change in the interaction I shared. Just, this is new for all of us. Let me right now relieve you of the burden to solve all of the problems on your own, in your own health system. Engage your patients and families into that process. It gives us confidence, it gives us comfort to be able to be part of how do we set this up together? How do we design this care together? Eliminate distractions as much as you can. That happens with patients and families, and it happens with our clinicians, right? I think I've seen more dogs, cats, and children in the last 3 months on all of our colleagues' calls, which is okay. It's humanity. And so I think just acknowledging that and embracing it is really helpful. Patients really are still looking for that invitation into the interaction. So again, the comfort level and the relationship, if you've got prior relationship, then really drawing and leaning into that, leaning into the details you know about that individual and inviting that out. If you don't have existing relationship, then, you know, just sort of inviting that. Tell me something about yourself. How are you doing with all of this? And again, offering the opportunity to ask questions. All right, and in the post-visit, so this is the area that I've really heard a lot about is getting dropped off. So where is the post-visit summary? Is there still a written summary? Is it coming through the portal? Am I expected to go find it there? Or are you going to email it to me? Will you be texting it to me? How will I get that information? So how will how will we stay together on this path? Access to follow-up care, we've heard this as well. If you are telling me to go get an MRI, where am I going to go? How am I going to get that prescription? All of these details that are typically at the post-visit summary are not necessarily coming through in this technology space. So really paying attention to that. And then the evaluation. We're hearing a lot of Press Ganey surveys following the interactions, which is great in terms of ascertaining what the person's experience with the visit was, but I would also encourage you to add a couple of open-ended questions for quality improvement. Like, how could we make this better together? How could we improve on your experience here? So really important, again, to think about this with a QI perspective and invite your patients and families in to help you co-design those solutions. Next slide, please, and I think I'm on close to my end time. This is the virtual visit guide that the PFANETWORK members designed together with the leadership of the Health IT PFAC. So it's a really simple guide for patients and families, from patients and families. Our wonderful partners at LA County Department of Health Services translated it for us, so it's also available in Spanish, and we'll put the link in. You're welcome to share that with any patient population. But so I guess in summary, keep in touch with your patients and families, have a focus group, have a conversation, have a survey, and include us in how we design telehealth. Thanks so much.
Thank you, Libby. And don't see any clarifying questions in the chat right now. So go ahead and if there's any that come to you as you're thinking about Libby's presentation, input them and we'll handle them after Dr. Fiona Wilson presents. So on to the next slide. We've heard about patient outreach and what patients are saying. So now we're going to hear a clinician perspective who's been providing telehealth. Before we do so, I'd love to have another reflection opportunity. So think right now, how can providers and staff best support patients to promote telehealth or virtual care most effectively? So let's stop and take a few seconds to reflect and share your feedback in the chat. And Dr. Wilson, will go ahead and hand over to you after we see a couple of responses coming in. Okay, we actually didn't see any good ideas coming from folks as of yet. So in the interest of time, I'm going to hand it over to Dr. Fiona Wilson. And if you have any ideas later, feel free to chat those in. Dr. Wilson?
Okay, hope you guys can hear me just fine. So hello again for those of you who I worked with in PTI. So as you guys know, as PTI wrapped up, I also took a little bit of a professional hiatus. I traveled this fall, which was great because it's hard to travel now. And as I came back and started to think about what do I want to do next, I was actually kind of curious about the telemedicine space. I just thought, I don't really know anything about this. I don't see myself as a tech person. I've been always more of a hands-on kind of primary care physician. And so I reached out to this company called Teledoc. Sorry for the size of the icon here. I'm not trying to be a true advertiser for them, but I reached out to them and joined their physician pool in February. So note the month, February. And it was sort of interesting. And I'll tell you a little bit about how that works. And then we'll get into how the dates changed. Teledoc itself, it's a national company. Actually, I think you can even do some international visits. It's in every state, and from what I understand, it is a benefit that often happens. Folks that might be in a union might get that as an extra added benefit to their benefits package. Some health plans contract with them, and it's really trying to provide some piece of non-face-to-face care. So we'll get into what that is. A little bit different, though, I would say, than the webinar that many of you may have participated in about a month ago, where we heard a lot from Telehealth, who does really, they're an amazing primary care or telehealth practice that really have a kind of a deep technology and virtual component and expectation of their work. This is much more single visit kinds of interactions. So maybe next slide there, Jose. Am I driving? There we go. So, I mean, what changed is I started working for them in February. I'm credentialed in California. Oh my gosh, a pandemic comes, offices close, and suddenly there is no access. So for me personally, I went from being credentialed with them in one state to I think I'm now conditionally credentialed in 30 states. And it meant that I ended up talking to patients from around the country, which was in its own, as an aside, just fascinating. But it suddenly was pushed into this realm of people have very, very limited access. Many offices in March didn't really even have anything started about how do they manage. They just closed. This was particularly true in small offices where there seemed to be no availability, no clear access. So thus the call queue certainly opened up. And clearly there was, when I say a high need for contact, people, if you think of what we all were thinking in March, the news was full of the rush to find ventilators. So it kind of was the extreme bookend of COVID without really any context of the likelihood or the prevalence. And we were really trying to get our hands around it sort of clinically, medically. Every place was planning for a huge tsunami. So patients are at home. I can't reach my doctor. I have a question and I might be hit by the tsunami. So I think there was a lot of lack of understanding, just a huge amount of stress, which I'll talk about in a moment, that related to their, I don't have access, what is COVID, a huge amount of fears that were just quite amazing. So just to talk for a moment about the Teledoc process, because it is going to be different than some of the examples we've talked about. These are completely patient-initiated visits. They're phone or video. They log on to the portal. If they don't have actually that capability, they can call someone who actually inputs some information. And they have choices of phone or video. I will say it's still about 2/3 phone. So I think we tend to jump to the very tech side of it, but I think that the phone access is still so present, and I think we don't want to diss that just because it's not maybe as sexy in some way, and it has a lot less of the problems that video. And for patients, they will ask for a scheduled time, like I'd like to have a visit at, and they would say what time, or just on demand. They're just waiting for a call back. And as a provider, I'm just someone who then goes into a queue and I take the next call and I work with what I have. They have a proprietary problem-based EHR. It has prior call notes, but doesn't really have anything about their prior history unless they've chosen to put something in. And even when it's in there, it's really pretty rudimentary. It does have pharmacy data, so that is super helpful because the patient may be requesting a call around a rash, but I can actually see what their recent fill rates are on their diabetes meds. I can see actually a lot of information, which then I can choose how I want to weave into our discussion. And they may choose to upload some images, some notes, some information that could be helpful. And I can also look at ones that may have happened in the past. So rash is a great example. They might have shown a picture a week ago and I can see what has happened in terms of progress. So I'm going to make a couple observations and share them about sort of processes around this in general, and then really what's it like as a provider to be in this space. So again, this is a patient-initiated interaction. So they had to feel something as to why they said, I'm going to reach out. And so I think you have to remember that they are initiating it, and I have really no information on them, so to speak. My second bullet here, where I said the reason for the visit may misrepresent the problem. First off, there's clearly a menu of which they choose from, and you know how menus are. It doesn't always have the thing you really want to talk about, so there's that. But importantly, I think there's a whole lot that's underneath their request that is not going to be in their kind of, chief complaint from the menu. And I thought that was really important to sort of go beneath the chief complaint. People have reason, and maybe it is, I'm sticking with rash. I have this new rash. I think you always have to go a layer deeper about sort of, and what else? And obviously, it goes without saying, but I have to say, you have to trust the patient. These were patients for me, I have no prior history with. I have no sense of their social situation, their economic situation, their educational, I have nothing. So I really have to trust what I'm hearing and really go potentially deeper. I pointed out here that it's fine to sort of start the conversation in one place and start to take it someplace else, because I did feel that the agendas that people present with, and what really is also going on, those need to be sort of all brought out to sort of do whole person care. And I think when I first started doing this work, I thought, well, it's just going to be that rash. And then I realized, like, wow, there's actually such an opportunity to really provide good phone whole person care, you know, to someone who's in Indiana. I don't even know the state of Indiana. And you can do this all in the precious time of a single visit. So that's one of the limitations of this platform, is I have to sort of be as complete as possible, because that's going to be the only moment of interaction I have with this person. Let's go to the next slide here, actually. So a couple of provider issues. So I said to trust the patient. Let's trust the unknown patient. And I think as a provider, we often tend to, as a physician, we often depend on the other stuff that comes in from the professional tools and the peers and the other notes. And what I kind of loved and had to get used to was, I don't have really much of that, a little bit of pharmacy fill information, but I really have to hear it all from this person. And yes, it does mean taking a really good and deep history, because that's all I have to go on, is what are they sharing with me? And again, I don't have a lot of history to go on, but I also have sort of the time to go where I need to with that. And again, this is going to be sort of, as a provider, we often say, well, I've always done it this way. I always systematically go through, this is the way I do my notes. This is where I look in the chart, note my paper, my old school kind of flipping through the paper, but I look through. And when you don't have that, you have to, as the provider, me, had to let go of my prior kind of bias and patterns. So to Libby's point of, like, it's messy, it's totally messy, but you kind of have to embrace its messiness. And I think I said much can be diagnosed with a good history, including, oh, we actually can't figure this out any farther here, and here's what we need to do next. So I gave a couple of examples. If someone's got a fever and ear pain historically, we're going to look in the ear. Well, I can't. Am I really going to say now I'm comfortable treating somebody for what I think their problem is? Or I might have a topic such as abdominal pain, where I can get only so far and say, you know what, this really needs a laying on of hands. We really need to have somebody see this, and here's why. I think the other thing is, physicians are often driven by the very low but serious outcome of a handful of things. And those often drive us to sort of look a little farther, cast a net more broadly. I think in this situation, it's been so interesting to me that so few patients needed to go elsewhere. They didn't need to go to an urgent care. They didn't need to go to an ER. But you need to always sort of keep that sort of alive and thinking about what's the likelihood of that. Let me go to the next slide. So for me, the other thing that was really kind of great and different is it wasn't time limited. Patients weren't really cutting on the line with me or video because they were going to talk for an hour. They came in with an expectation of a level of interaction. But I never had, as I would as a provider, that kind of knock at the door of who's next, I need to wrap this up. And I know for me, there was a lot of freedom to that I felt very open to sort of ask much broader open questions about where they are, with the usual caveat that we actually kind of got there and things wrapped up in not an unreasonable period of time. I felt it was important with the pandemic to really explore their social situation. That included their own personal safety. So whether that means, are they out working in the field? What does that mean in terms of following guidelines for distancing, covering, et cetera? Or are they crammed in a house and there's a lot of tensions? There's a lot of questions around safety that, again, were really, I encourage myself to sort of open up and ask. Employment is hanging on everybody, where there's lots of uncertainty in lots of households. It doesn't take a lot of science to realize, like, those can be sort of powder kegs of challenge. And so again, trying to take the issue, the example, the rash in the context of how is this whole person and what's their environment. I found that there were really a lot of concerns and fears and, you know, anxiety and depression that just is, if it's not on the surface, it's a millimeter under. And I think that part of what, I wasn't necessarily going to solve those issues or problems with an individual, but I was going to shine a light on it and kind of normalize a lot of what they're feeling, because I do feel we with so many patients around this. And then lastly, this really got to Libby's point too. Because this was my single interaction, I felt it was really important to give very clear written guidance. I probably did bigger after visit summaries than I have in other settings because I didn't really know what would be the next thing for them. And so I really spelled things out, spelled out next steps in a way that I might have, you know, in my own practice, I might have said, oh, you know, just call back in. Don't really know what that means for that person. So I'm really trying to make the most out of that. I think maybe there's one more slide.
Yeah, Dr. Wilson, could we ask you to cover the next 2 slides in a minute or less? We want to leave a little bit of time for Q&A. Thanks.
Absolutely. So what I would just say is this has been surprisingly successful. Patients, as we saw the data, very satisfied. I've never had as much appreciation in people that I'm talking with than I have in the past. And I think what for me, I sort of said, caring-based is almost greater than relationship-based. I came from a relationship-based setting and just realized like, oh, if we provide some amount of structure, we can actually do this very easily. I do not think it's gonna go away. And then I think last slide, I'll talk even faster. I think a lot of you already do this. I think we didn't call it anything different than a callback at the end of practice. And I think that one of the things that we need to do is add some more structure. There's actually structure and some compensation, and patients are really expecting this now. And I think demand on this, it's only going to grow. So I think it's a great start, and nothing like a pandemic to sort of push ourselves quickly into transformation. I'll stop there.
Thank you so much, and thank you for speeding up at the end too. So we have a little bit of time for questions. I want to go ahead and go back to one that was put in the chat by April. Thinking about how virtual modality may be an extension or have enhancement of the in-person relationship with the care team, what sort of evidence or experience have you seen for how to best establish relationships between patients and care teams in a virtual setting? But maybe we can go to Libby first.
Sure. So I think, you know, assuming that your question refers to folks that you're engaging for the first time that you've not seen in clinics before, then, you know, I think level setting the conversation right up front, you know, doing all those pieces ahead of time to offer a run through if possible. But once you're on the visit with the clinician, I think, you know, opening the space that this is a new time, a new way to work, introducing them to your surroundings, so what they might be seeing in the background. This is my office. I'm here because nobody else is here, and you know, we're level setting that, kind of making it a safe environment, I think is really helpful that way. And then again, just inviting them to share with you what's most important to them at this point in time, and do they have any concerns, and you know, using some of the other strategies, teach back, to help you ensure that you're both on the same page and in the same space in terms of your relationship. So those are just a couple of quick ideas of establishing relationships.
Yeah. Thanks, Libby. Dr. Wilson, would you add anything?
Yeah, I mean, I think teach back is such a good one. And, you know, again, you see my example, like I only have that visit, so I really want to hear. And if I'm not hearing it, let's make sure we spend time on the things that are most important. So I think that that's really key. Yeah. I think the other thing is really just normalizing this as part of sort of the menu of things that are going to need to happen in clinical care. And it may have turned up in this and move into sort of a normal part of the sort of healthcare menu for all the reasons we talked about.
So I have one other question that I'm hoping we can cover, and this is what I would like you to think about. We've all agreed that this is an opportunity for broadening telehealth, and that there's work to be done about making workflows more patient-centered. What one piece of advice would you offer for small practices and IPAs that they might think about as they're making their virtual workflows more patient-centered? And we'll start with you, Dr. Lyles.
Yeah, I would say I would really go back to having the conversation. I mean, everything that the other two speakers have said is just right on in terms of normalizing it and asking people what they prefer and need. I think to me is my best advice. Of course, I would add, when you're doing that, understanding what technology they have and what they feel comfortable with, to me, is the thing I would leave you with, like making sure that that includes both their relationship and also, I have to use the device to talk to you right now. What would be the best way for us to do that, and can I help you with that?
Thanks. Libby?
Yeah, I think I would say look to your patients and families as a resource to designing your telehealth, your telemedicine program. Outside even the visit, but really tapping back into through focus groups, through open-ended surveys, through just telephone calls or an advisory program, but tapping into the people with the lived experience using your telehealth medicine to help you continuously improve it.
Mm-hmm. Thank you. And Dr. Wilson?
Yeah, I think just make it as simple as you can. I think sometimes technology can be part of the barrier, and I understand that, but at the same time, pretty much everybody has a phone and pretty much everybody can talk on that. So at least start with the tools you have, and certainly if you want to grow in terms of complexity, that's great, but I think we have there's few people that don't have a phone, so just start with that, and it doesn't have to be a smartphone.
So I think we heard preference, patient advisors, and simplicity. I want to thank our speakers so much and all of you for joining us on this webinar. I have a few closing slides. Jose, if you wouldn't mind advancing. In the deck, you'll find a link to the Primary Care Collaborative Survey, a national unit that's doing some tracking of impact of COVID-19. We encourage you to take the survey if you're able to. Jose is going to run a final poll for how this webinar met your needs today. So thanks so much for providing us that feedback. And our last slide is make sure to please stay connected to CQC. We're planning another webinar for early June on providing care in this new normal era. And I just want to thank Dr. Lyles, Libby, and Dr. Wilson. This was such a fantastic wealth of resources, and we very much value your preparation and presentation during really busy times. So thank you.
Thank you.
Take care, everyone. Bye-bye.
All right, thanks so much. Bye.
Thank you.
Thank you.